So hi everyone, today we'll be discussing about abnormalities of pupil and another short topic in your ophthalm, that is optic neuritis. So visual pathway and pupillary reflex pathway and near reflex pathway were covered in the previous classes. So we'll be continuing with the abnormalities of this pupil as well as pupillary reflexes. So coming to pupil. So what is pupil? Pupil is nothing but an aperture which is located at the center of the iris. So what are the main functions of the pupil? It is to regulate the amount of light which is reaching the retina. So if it is bright light, it constricts. If it is dim light, it dilates and allows more light to enter into the retina. So it improves the optical quality of the image formed on the retina by reducing the optical aberrations, and it also increases the depth of focus. So another function is it allows the flow of aqueous humor from posterior chamber to anterior chamber and through the angles. So these are the important functions of pupil. So as you know, anatomy of the pupil, we have one in number usually, and the location is at the center of the iris. It is circular in shape, and the color of the pupil actually doesn't have any color. Since it is an aperture, it takes the color of the structures behind it, like if based on the color of the lens or vitreous, like you can see the reflex. So the size is approximately around 3 to 4 millimeter. It is not fixed, it depends on the conditions such as illumination as well as some physiological changes. So in extremes of age, the pupil can be smaller, like in case of children, and old age it can be small, that we call it as senile meiosis, and usually it's around 3 to 4 millimeter. So you know that pupils are usually equal in size in both the eyes, that is called isochoria. If there is a variation in the size of the pupil in between both eyes, it is called anisocoria. So there are some conditions where I mean physiologically also, like you can see in few people without any conditions, like without any like diseases or something, they can have slight variation in the size of the pupil. So that is called physiological anisocoria, but it will be usually lesser. It will be less than 0.4 mm or 0.6 mm. So and there won't be any variation in the size of the pupils in dim light or bright light. It will be fixed. So that is called physiological anisocoria, but always you have to differentiate it from pathological conditions. So then coming to the anatomy. So the size of the pupil, it is regulated by two muscles. This is very important because if these pathways are affected, like sympathetic and parasympathetic pathways, the pupil size will be affected. So the iris is made up of two muscles, that is sphincter pupillae and dilator pupillae, which are responsible for regulation of the size of pupils. Sphincter pupillae are circular and it is just adjacent to the pupillary margin. So it is responsible for constriction of the pupil in bright light. It is supplied by parasympathetic nerve supply. So any damage to the parasympathetic nerve supply, third nerve, ciliary ganglion, it can lead to dilated pupil. So dilated pupil because the sphincter pupillae, which is responsible for constriction, is getting affected, and the other muscle is dilator pupillae, like you can see in this picture, the radial muscles which is far from the pupillary margin, that is dilator pupillae. It is supplied by sympathetic nerve supply. So in case of sympathetic paralysis, the pupil, which is supposed to dilate in case of dim illumination, remains constricted. So this is the importance of knowing the nerve supply, sympathetic and parasympathetic nerve supply to these two muscles. So like you can see in this picture, two muscles, sphincter pupillae and dilator pupillae, and sympathetic nerves, the dilator pupillae getting dilated on dim illumination, which is supplied by sympathetic nerve supply, and sphincter pupillae, which is getting constricted on bright light, this is supplied by parasympathetic nerve supply. So this nerve supply is very important. Then coming to some morphological abnormalities of pupil. So I told you, pupil is only one in number, but there are few conditions and few diseases where you can see 2 to 3 pupils, then it is called polychoria. When the number of pupil is more than one, it is called polychoria. And based on the position of the pupil, usually it is at center of the cornea or eyeball, but if it is located eccentrically, it is called correctopia. So, and based on the shape of the pupil, abnormalities of the shape of the pupil, D-shaped pupil, D-shaped pupil is usually seen in iridodialysis, where there is disinsertion of the iris from its root. You can see here a D-shaped pupil because of the disinsertion of iris. This can be secondary to trauma or some surgical complications, cataract surgery or something. So the next one is festoon pupil. Festoon pupil, it occurs in uveitis, where there are anterior synechae between the iris and lens capsule. If there is a synechae, irregular synechae, so it will appear in the form of festoon pupil. And the next image, you can see a pear-shaped pupil. Pear-shaped pupil, when there is a peripheral corneal tear or when there are corneal ulcer perforates, the iris will come and adhere to that part of the cornea, and it will give a pear-shaped pupil in case of adherent glaucoma. So the next is a oval and fixed pupil you will see in glaucoma. Oval and fixed pupil, because of sphincter atrophy, you can see a fixed oval pupil in case of glaucoma. And color of the pupil, like I told you, it doesn't have any color. It takes a color behind the the structures behind the pupil gives it the color. Like in case of in mature cataract, you can see grayish white reflex. In case of mature cataract, you can see white reflex. And other conditions like retinal conditions, or the differential diagnosis of leukocoria based on the vitreous condition or retinal condition, you can see leukocoria. And if in case of endophthalmitis, you can see a grayish reflex because of the vitreous exudates. Yellowish reflex because of the vitreous exudates. See, like in the last picture, there is a yellow reflex. It is usually seen in endophthalmitis. And white reflex, multiple number of conditions like retinoblastoma, PHPV. You have ROP. There are a list of conditions, right? So all those conditions can lead to leukocoria, as well as even congenital cataract comes under leukocoria. So like I told you, like if the pupils are equal in size, it is called isocoria. If there is a variation in the size between the two pupils, it is called anisocoria. So you need to know where a few abnormal conditions where pupils are very small or pupils are dilated, like mydriasis and meiosis, that I will be putting in the next slide. So these are the conditions. Like physiological anisocoria, like I told you, the variation between both eyes is less than 0.4 to 0.6 millimeter difference, and it is normal both in the dark and light. It doesn't vary. The pupil size will remain the same. The difference between the pupil, not the pupil size, the difference between the pupillary size will remain the same. Though the pupil will get dilated in dim illumination and constricted in bright illumination, the difference between both of them will remain the same. It will be around 0.4 millimeter. But there are few conditions, pathological anisocoria, if it is related to sympathetic or parasympathetic nerve supply damage, where we see pathological anisocoria, you will see the variation in bright light and dim light. So that we'll be discussing later. And they ask, what are the causes of meiosis? So one is, these are the conditions where commonly you see meiosis. I told one is physiologically in extremes of ages, in old age and young age you will see meiosis. Then use of local meiotic drops or some systemic morphine poisoning. Then iridocyclitis, initially you can see meiotic pupil. Then Horner syndrome. Then pontine hemorrhage. In case of pontine hemorrhage, you can see small small pupils. Then exposure to strong light and sleep also. In sleep also you can see small pupils. And what are the causes for mydriasis or dilated pupil? So one is use of most common is in OPD, like we use pharmacological agents to dilate the pupil. That is the most common cause of mydriasis. Then sphincter tears. Sphincter tear can lead to dilated pupil. Then ophthalmoplegia, internal ophthalmoplegia, as well as third nerve palsy, because third nerve carries the parasympathetic fibers for pupillary dilatation. That is, it carries a parasympathetic nerve supply which supply the sphincter pupillae, which is responsible for constriction. If there is a paralysis of that, the pupil will be dilated, it can't get constricted. So third nerve palsy is one of the common cause of mydriasis. Then in case of belladonna poisoning, all these are common causes of mydriasis. So coming to abnormalities of pupillary reflexes, so in this what you need to know is few have been asked as short note for you. In that, most common are, in case of afferent pathway defects, they have asked relative afferent pathway defect or RAPD or Marcus gun pupil. So this is being commonly asked, but you need to know all this for your entrance part of view also. Like coming to the afferent pathway defect, afferent pathway, as you know, the afferent pathway consists of the optic nerve, optic chiasma, optic tract, then lateral geniculate body, optic radiations, all these comes under, then the visual cortex, all this comes in afferent pathway. Then the efferent pathway is from the pretectal nucleus to the Edinger-Westphal nucleus, then the third nerve, the preganglionic parasympathetic and all comes through that, then the ciliary ganglion, then the postganglionic parasympathetic nerve fibers, from there to the sphincter pupillae. This is the afferent and efferent pathway for light reflex. So then there is something called like it was explained, near reflex and convergence reflex. You need to know the pathway of all these three. What is a pathway for direct light reflex and what is a pathway for indirect light reflex? So indirect, nothing but because of the crossing of the fibers in the pretectal nucleus to the opposite third nerve nucleus, opposite Edinger-Westphal nucleus, you will have consensual light reflex. That is, when one eye is stimulated, even the other eye will get constricted. It is mainly because of the crossing of the fibers from pretectal to the Edinger-Westphal nucleus in the midbrain. So what are the afferent pathway defects you need to know? One is total afferent pupillary defect, then another one is relative afferent pupillary defect, then the other one is Wernickes Heminopic pupil. These three you need to know in short. Then efferent pathway defect. Efferent pathway defect, there are few conditions like tonic pupil, oculomotor nerve palsy. Oculomotor nerve palsy is again a separate topic. So here I will be covering only about Adistoin Pupil. Then there are few conditions where there is light near dissociation, wherein the light reflex will be present, and but the light reflex will be absent, but the near reflex will be present. So that one important condition is Argyll-Robertson pupil. So you can just remember Argyll-Robertson pupil, A for accommodation, R for reflex, and P for present. So accommodation reflex is present, but the light reflex will be absent. I'll explain about this later. Then there is something, if there is a paralysis of sympathetic plexus or postganglionic sympathetic or preganglionic sympathetic plexus, it leads to Horner syndrome. So you need to know about few abnormalities of pupillary pathways or pupillary reflexes. So one is total like coming to the afferent pathway, that is optic nerve, optic chiasma. So one is total afferent pupillary defect. So total afferent pupillary defect, it is also called amerotic light reflex. It refers to it usually occurs in conditions where there is a complete optic nerve damage or complete retinal lesion. So complete damage to the optic nerve, and usually they'll have a PL negative vision. Then you can see this amerotic light reflex, where there is absence of both direct light reflex on the affected side and even the consensual light reflex on the normal side, because the afferent pathway is completely damaged. So when you shine a light to the affected eye, the pupil will there will be absence of light reflex. The pupil doesn't constrict because the afferent pathway is completely damaged. There is no signals which are going to the brain. So the pupil remains the same, it doesn't constrict. And since there is no transmission of the information, even the other eye, the normal eye, is not getting constricted. So both pupils are getting dilated. So but wherein if you put the light to the normal eye will constrict, and even the affected eye also will constrict because of the consensual light reflex. So this is total afferent pupillary pathway defect. So what is relative afferent pathway defect or relative afferent pupillary defect or Marcus gun pupil? So it is also similar to TAPD, but a milder form of TAPD. So here there won't be abnormal, as soon as you see, you won't make out such abnormalities in the pupillary size. But so usually it occurs in conditions where there are incomplete optic nerve lesions, even a milder optic nerve, early stage of optic nerve lesions or incomplete optic nerve lesions or severe retinal diseases. You can see this type of reflex. So how do we elicit this? This is done by a swinging flashlight test. You need to shine a torch to one eye, and within 2 to 3 seconds you need to move to the other eye, and again back to the normal eye, again back to the other eye. So this has to be done. So what happens is, when you are, so in this picture what we have shown here, the left eye is abnormal. So when you are showing the light to the right eye is getting constricted because the light eye pathway, afferent pathway, is completely normal, and there will be constriction of the affected eye also, because to the consensual pathway, the consensual light reflex. But when you take back the light to the abnormal eye, that is the left eye is getting dilated instead of getting constricted, and because of that afferent pathway defect in the left eye, so the informations are not going, it is not taking the information to the protected nucleus, and hence there won't be any crossing of fibers and all. Even the other eye consensual light reflex will be affected. So when you bring back the eye to the normal side, again both the pupils will constrict. So this is a relative afferent pupillary defect. It is called relative afferent pupillary defect because it is we are comparing to the other eye, to the normal eye. So that's why it is called relative afferent pupillary defect. But this can't be elicited if both eyes are affected. If the both eyes are equally damaged, both eye optic nerve is equally damaged, or the severe retinal lesions, you can't elicit RAPD with. This is only a relative afferent pupillary defect. So this is elicited by swinging flashlight test. And what are the conditions which causes RAPD? You need to know, like optic nerve disorders and retinal causes. You can divide them. So optic nerve diseases, anything like any incomplete or any mild lesion affecting the optic nerve can cause RAPD. Like RAPD usually it occurs prior to the optic chiasma or only up to the optic chiasma. After that, even in the optic tract lesions you can have RAPD, but that is again, that pupil reflex is called something else, that is Wernickes Heminopic pupil, that we'll be discussing. So RAPD, just remember, it occurs only in case of lesions prior to the chiasma or occasionally in optic tract lesions also. So optic nerve diseases like optic neuritis, ischemic optic neuropathies, glaucoma, traumatic optic neuropathy, optic nerve compression, optic atrophy, all this can lead to RAPD. And retinal causes like vein occlusions, artery occlusions, retinal detachments, these are the important conditions where you can see RAPD. So next, coming to Wernickes Heminopic pupil, like I told you, this occurs in optic tract lesion. So what is happening here? As you know, optic tract, like anatomy of visual pathway was discussed in the previous class. Optic tract is carrying the fibers from the ipsilateral temporal part of the retina and contralateral nasal part of the retina. Nasal fibers, it means that it is if the right optic tract is getting affected, it is carrying the field information from the left side, because the light rays from the as you know, the light rays from the nasal part are falling on the temporal retina. From the temporal part of the visual field, they are falling the nasal retina. So the right optic tract is carrying information from the left visual field. So when you shine a light on the, if the right optic tract is involved, if you shine a light on the right nasal retina, then there will be a relative afferent pupillary defect sort of reaction, but still we won't be able to elicit it properly, because usually we can't shine a light only on the nasal retina or only on the temporal retina. It is difficult because of the scattering of light within the eye, so we won't be able to clearly make it out. But ideally, what has to happen is, if you are shining a light on the nasal retina, on the nasal side of the eye, the temporal retinal fibers have to be stimulated. But since there is an optic tract lesion, so you will have a afferent pathway defect. You will have a relative RAPD in the right eye, and in the left eye, if you shine a light on the temporal side, you will have the similar reaction. So this is Wernickes Heminopic pupil. See, like I showed you, affected side, when you shine, the nasal half of the retina is stimulated, and the opposite side, the temporal half of the retina is stimulated. So you will have this relative defect. So coming to this was about the afferent pathway defects. Now coming to the efferent pathway. As you know, the efferent pathway is the third nerve. So any lesions within the third nerve will lead to efferent pathway defects. Third nerve or ciliary ganglion or the short ciliary nerves, all this will lead to efferent pathway defects. In the efferent pathway, so on simulating the affected eye, the direct light reflex and the near reflex will be absent, but the consensual right reflex will be present. Consensual light reflex will be present because of the because the other eye, third nerve, is normal, right? So but this eye, though the efferent pathway is normal, the efferent pathway is affected. So though you stimulate the eye with the light, the third nerve, which is responsible for constriction, is affected. So both the direct and the consensual right reflex, consensual because the third nerve is affected, the efferent pathway is affected. So if you stimulate the other eye also, the affected eye doesn't constrict. Both the direct and consensual right reflex both the direct light reflex and the near reflex are absent, but the consensual right reflex will be present, simulating the affected eye. So coming to few afferent pathway defects, like third nerve is a separate topic. So we'll be dealing with Adistoin tonic pupil. So Adistoin tonic pupil, you basically remember it as a lazy pupil or a slow reacting pupil. It is a slow. So the reason for it is clearly not known till now. It is thought to be because of some post-viral illness or some inflammation leading to of the ciliary ganglion and the short ciliary nerves, leading to this type of pupil. So it is usually associated with areflexia. Deep tendon reflexes will get affected. So it is mainly thought, the main pathology is within the post-ganglionic nerve supply, that is involving the short ciliary nerves, which are supplying the sphincter pupillae. So it is usually unilateral in 80% of the cases, and females are more affected when compared to men. What is happening here is the affected pupil is tonic. It is larger in size, and it the next line is wrong actually. So it reacts to they say it doesn't react to light. If it reacts also, it reacts very slowly to the light. So it takes some time, it reacts very slowly, and if it reacts also, it will remain in that position for some time, and again it will start dilating. So but the reaction to light is very poor, whereas the accommodation reflex can be present. So this is also one cause wherein there is light near dissociation, wherein the light reflex is absent but the near reflex is present. So this is also one condition. But they say this Adistoin pupil, it very slowly reacts to the light and again remains in that position for some time and again dilates, and there will be slow accommodative reflex also. So it is basically a slow moving pupil, and there can be some vermiform movements of the pupil. Because of the irregular innervation, there can be some movements of the pupil. So a very slow and tonic accommodative reflex can be there, and characteristic feature is that it responds to a very small percentage of pilocarpine. If you're putting pilocarpine into the eye, usually the percentage of pilocarpine is used to constrict is 0.1%, but it responds to even 0.125% of pilocarpine, and it gets it constricts rapidly. So this is the characteristic features of Aedes pupil. So here you can see the pupil is large. In case of bright light, if you're putting light also, the pupil doesn't constrict. So whereas in case of so the anisocoria is there and it is more in the bright light because the pupil is not constricting to the light. Alright, so in case of dim illumination, both are getting dilated and the anisocoria is not much. So this is also one cause wherein there is accommodation reflex will be present, where light reflex is abnormal. So there is light near disparity. So other important condition where there is an light near dissociation is Argyll-Robertson pupil. Like I told you, it occurs usually in case of pretectal lesions, pretectal or dorsal midbrain lesions. it was more common before because neurosyphilis, which is more prominent, which involves the pretectal nucleus or dorsal midbrain, it can lead to this type of pupil. So this is one condition where the name I told you to remember: A for accommodation, R for reflex, and P for present. Accommodation reflex will be present, but light reflex will be absent. So because the pretectal nucleus is the center for the light reflex, if that is involved, the light reflex will be absent because the main nucleus is getting affected, whereas the accommodation reflex, which has the center in the frontal and the cortex, it is intact, and the accommodation reflex will be present. And here the pupils usually they'll be smaller in size in contrast to the Aedes pupil, which is large, because there the postganglionic nerve supply is getting affected. But here, because of a nuclear lesion or a supranuclear lesion, the pupils are small and irregular in size, and they don't react to the light at all. But to the near reflex, they when you show the pen or something, they constrict, like you can see in this picture. To the light, it is not getting constricted, but when you are bringing a pen, the pupil is getting constricted. So this is a condition wherein the accommodation reflex or the near reflex will be present, whereas light reflex will be absent. The other causes of light near dissociations are any afferent pathways, like optic nerve lesion. All these can lead to light reflex absence of light reflex, but accommodation reflex will be present. And another cause is Aedes pupil, like I described in the last slide. But in Aedes pupil, you can have a slow reaction sometimes. It is not complete absence, it can be slow reaction to light. Then coming to Horner syndrome. Horner syndrome is a condition wherein there is sympathetic nerve supply gets affected. So Horner syndrome can lead to ptosis, meiosis, anhidrosis, that is lack of sweating or lack of because of the sympathetic nerve supply, which is responsible for sweat secretion. You can have anhidrosis and heterochromia iridis. So these are the characteristic features of Horner syndrome. Like you can see in this picture, the left, like there is a ptosis, meiosis, anhidrosis, and dilatation lag, and heterochromia iridis, the variation in the iris color between both eyes. So in this, again, based on the location, it is where the sympathetic plexus is getting affected. Like sympathetic plexus is divided again into central supply, then the preganglionic and postganglionic. Central is from the hypothalamus to the ciliospinal center of Butch, and from there to the superior cervical ganglion, which is located over the apex of the lung. It is a preganglionic, and from there to the dilator pupillae through the ciliary body, it is a postganglionic. So anywhere it can get affected. So it is important to identify Horner syndrome because it can be a presenting feature sometimes of a very severe conditions, like dissecting carotid artery aneurysm or the carcinoma of apex of lung. So sometimes it can be the initial presenting feature of some serious disorders. So then coming to another short topic, today we'll be discussing about optic neuritis. So optic neuritis is nothing but inflammation of the optic nerve. So it is classified into based on the ophthalmoscopic classification, like based on the structures of the eye involved, and another one is based on the etiological classification. Ophthalmoscopically, it is divided into retrobulbar neuritis, wherein the retrobulbar portion, that is behind the eyeball, the retrobulbar portion of the eye is optic nerve is involved. Then the main optic nerve head or the disc is involved, that is papillitis, and if the disc as well as the retina is involved, it is called neuroretinitis. So this is based on ophthalmoscopic classification. And coming to the etiology, based on what are the causes of optic neuritis, like demyelinating diseases, then infectious causes, para-infectious causes, and other autoimmune causes. So based on the etiology, it is again subdivided into this. So coming to ophthalmoscopic classification, we'll be discussing about each. So what do you see in retrobulbar neuritis? What do you see in papillitis? What do you see in neuroretinitis? So first one is retrobulbar neuritis. Like I told you, the retrobulbar portion of the optic nerve is getting affected. So in this, you don't see any clinical features. So the optic nerve will completely appear normal, and sometimes, very rarely, you can see some edema or some temporal pallor. So this is a condition where we call, like, wherein both the doctor doesn't see nor the patient doesn't see, because the patient's vision would have been affected because of the retrobulbar portion of the optic nerve is getting affected, and the doctor is not seeing any findings. So there is a condition which is described where the patient sees nothing and the doctor sees nothing. So most of the conditions it will be normal, but in few cases there can be some edema and pallor. So this type of optic neuritis, which is called retrobulbar neuritis, is usually seen in demyelinating diseases. Demyelinating diseases, in that most important for you to rule out is multiple sclerosis is one of the important demyelinating diseases which has to be ruled out. Then next is papillitis. Papillitis, like I told you, like when the optic nerve head is involved, that is, there will be hyperemia and edema of the optic disc. Like you can see in the middle picture, there is hyperemia and edema of the optic disc, and associated with peripapillary flame shaped hemorrhages can be present. So this is most commonly seen in children. This papillitis, it is most commonly seen in children, and it is associated with para-infectious type of optic neuritis. Then coming to neuroretinitis. Neuroretinitis, like I told you, here along with the optic disc, even the retinal nerve fiber layers, especially of the macula, are involved. So along with this papillitis, along with the disc inflammation, you can see multiple hard exudates within the macula, like fan shaped exudates or macular star, we call it as. So if along with its optic disc edema you will have the macular star, it is called neuroretinitis. So these are based on ophthalmoscopic classification. And coming to the etiological classification, I told you, like demyelinating diseases, para-infectious are nothing but viral infection, or it can sometimes happen secondary to even immunization of mumps, measles and all. Then infectious causes, more common infectious causes are cat scratch fever, syphilis, Lyme's disease, cryptococcal meningitis. All this can also lead to optic neuritis, and rarely some non-infectious causes like autoimmune diseases and sarcoidosis can lead to optic neuritis. So here we need to know about the demyelinating diseases which are causing optic neuritis. So most important thing which we need to rule out is multiple sclerosis. In demyelinating disease, you can have isolated optic neuritis wherein only the optic nerve is involved without any systemic involvement. Then the other important thing I told you, multiple sclerosis, which is by far the most common cause of demyelinating diseases. And very rare diseases like Defect's disease and Schilder's disease also you need to remember. Defect's disease is nothing but it is also called neuromyelitis optica. So wherein there will be bilateral optic neuritis as well as with the spinal cord involvement, that is transverse myelitis. So which occurs within days or weeks after optic neuritis. And another is Schilder's disease, wherein you'll have a generalized disease within the age of 10 years and death occurs at a very young age. So these are the causes of demyelinating diseases which is involved, which is associated with optic neuritis. So what are the clinical features in case of demyelinating optic neuritis? They present, it is a unilateral presentation, uniocular vision impairment, middle-aged people, most common in females, and sometimes it can be associated with the flashes or colored flashes or tiny white lights, that is called phosphenes. And in 90% of these patients, they'll have pain on ocular movements. So mild pain on they'll have mild pain which is exacerbated or increased on ocular movements. So and they can be associated with frontal headache. So coming to the signs, coming to the signs, the visual acuity will be reduced. Even in the symptoms, they'll have a sudden painful loss of vision. So in the signs, the vision acuity will be reduced. It can be up to 660, but rarely it will be worse. And other signs, like I told you, if it is a retrobulbar neuritis, the optic disc will be completely normal. And only in few cases you can see this disc edema and temporal pallor, like you can see in this picture. And along with the vision, not only the vision, the color, the contrast, sensitivity, all the optic nerve functions will get affected. So the color vision will be out of proportionally getting affected to the visual acuity. So though the visual acuity can be 618 or 624, but the color vision would have got grossly affected. So this is one pointer towards optic neuritis. The color vision is impaired. and very rarely you can see this temporal pallor and disc edema, but usually the disc will be completely normal. Then the course of the disease, so usually it progresses over 2 to 3 weeks and starts improving. So the condition rapidly improves over a period of 6 to 12 months without any treatment also. So the prognosis is good. In 90% of the patients, the visual acuity recovers back, so they will have a good visual acuity, but the color vision may sometimes get affected permanently. So, and there can be mild RAPD also, and only in 10% of the cases it progresses to a chronic optic neuritis. So treatment as such, it is a self-limiting disease. If we don't treat also, it get resolved. But only thing is, if it is a case of multiple sclerosis, there was a study called optic neuritis treatment trial, wherein they told early. I mean, when if the patient is put on early steroids, there can be less chance. I mean, the recurrence chances of multiple sclerosis can be reduced. So for that, we need to put them on IV methylprednisolone for 3 days, followed by oral steroids for 11 days. So this doesn't influence the visual outcome. You need to remember, it is mainly not for treatment but to prevent the relapses. And why is it important? Like I told you, so in 30% of the patients with multiple sclerosis, this can be the initial presenting feature. Like if the patient is coming with optic neuritis, this could be the initial presenting feature in 30% of the patients. And if it is a patient of multiple sclerosis, they can have a 50% chances of getting a episode of optic neuritis throughout in their lifetime. So that's why you need to remember this. Then coming to para-infectious optic neuritis, like I told you, it occurs secondary to viral infections. And you know, viral infections, these infections, mumps, measles, chickenpox, rubella, they are more common in children. So this type of optic neuritis is usually seen in children when compared to the adults, and these are self-resolving. So usually they occur within 1 to 3 weeks of the viral infection, and both the eyes can get involved. Then usually they'll have papillitis type of picture, and the prognosis for spontaneous visual recovery is very good, and the treatment is not required. They usually it is self-limiting and they recover themselves. But however, if the visual loss is severe and it is bilateral, then we need to put them on intravenous steroids. Then coming to infectious causes, the most common infections are cat scratch fever, Lyme, syphilis, cryptococcal, varicella zoster. In this, because it's an infectious pathology, you need to give them a specific infectious treatment if required. So in Lyme's disease, you see neuroretinitis type of picture, and the cryptococcal meningitis also you see neuroretinitis type of picture. So this is about optic neuritis. So thank you.